imagine the impossible, who inspire the world with their ideas, and strive to provide clear answers for early and accurate diagnosis, for better outcomes, for better health, for every patient. Bayer wants to join you and make this dream come true.
My journey continues, and I know I'm not alone. Because together, we can make a difference every day.
Good morning, everyone. Welcome to Best Young Presenter Award session. And I'm Jin Ho, the Scientific Officer of AO. And today, I would like to briefly introduce this Best Young Presenter Award session of Asci 2021. The Best Young Presenter Award was initiated in 2010 and to recognize young doctors in the Asci Annual Congress for their research work and presentation skills. The award winner is given a prize and the prize money of 1,000 US dollar, which is sponsored by Bayer at an official ceremony during the Congress. This year, we have selected 5 finalists for a Best Young Presenter Award session. And congratulations to all 5 finalists. The 5 finalists will present their pre-recorded presentations during this session. The first speaker is Dr. Jiane from China, and the title is MRI-derived global early diastolic longitudinal strain rate and prognosis of patients with heart failure with preserved ejection fraction. The second speaker will be Dr. Habibi Arifianto from Indonesia, and his title is Rest Perfusion Myocardial Computed Tomography, a novel imaging marker for left ventricular ejection fraction recovery in systolic heart failure patient. The third speaker is Dr. Bayan Zhuang, also from China, and the title is Identify Ischemia, Infarcted Hibernant, and Normal Myocardium by Stress and Rest T1 mapping without the application of gadolinium contrast agent. The fourth speaker is Dr. Eunju Kang from South Korea. And the title is Feasibility of a Deep Learning-Based Stair-Step Artifact Reduction in Coronal Reformation of Contrast-Enhanced chasticity. And the final speaker will be Dr. An No from Vietnam. And the title is Texture Analysis of Magnetic Resonance T1 Map and Extracellular Volume in Heart Failure compared with normal controls. The certificate of Best Young Presenter Award finalists will be mailed to all 5 finalists in hard copy. The final winner of Best Young Presenter Award will be announced in closing ceremony of Asci 2021. And good luck to all 5 finalists, and please enjoy this session. Thank you.
Good morning, professors. My name is He Jian from Fuai Hospital, National Center for Cardiovascular Disease. Today, I'm very pleased to share my presentation named Early Diastolic Longitudinal Strain Rate by MRI and Outcomes in Patients with Heart Failure with Preserved Ejection Fraction. Heart failure with preserved ejection fraction, also named half-path, showed growing short-term and long-term mortality, posing public health problem, accounting for 50% in heart failure patients. Abnormal left ventricular diastolic performance is an important pathophysiology mechanism underlying half-path due to elevated LV filling pressure and wall stiffness. There are three ways to define diastolic dysfunction. First, the gold reference is invasive measurement through catheter, while limited by radiation and invasion. The second way is tissue Doppler and speckle tracking in echocardiography, limited by sampled segmental abnormality and error. Then the emergent CMR feature tracking enable to quantity airway performance, especially diastolic dysfunction. In all strain parameters, early diastolic longitudinal strain rate, that is EGLSR, noted in the curves, shows priority in defining cardiac diastolic dysfunction. And our previous work has confirmed strong reproducibility and the diastolic value of airway EGLSR from CMR feature tracking in quantifying cardiac dysfunction of half-path. However, there are limited data regarding the prognostic value of early diastolic longitudinal strain rate in patients with half-path. So this study aimed to explore the association between the LV-EGLSR and the clinical outcomes in patients with half-path. In this retrospective study, patients with half-path who underwent CMR imaging and echocardiography were consecutively included from January 2010 to March 2013 in Fuai Hospital. Patients with typical heart failure symptoms or greater than NYHA 2 class, NT-proBNP greater than 125 picogram per milliliter, BNP greater than 33 picogram per milliliter at the time of diagnosis, LVEF greater than 50% were included. And patients with primary cardiomyopathy, acute coronary syndrome, and restrictive pericardial disease were excluded. The inclusion and exclusion criteria were also listed in the flow chart. This is the approach of echocardiography and CMR protocol and analysis. The primary composite outcomes of our study are all-cause death or heart failure hospitalization, and we used these statistical analysis methods. In this figure, strain analyses were performed on a stack of short axis views and a 2, 3, and 4 chamber view. Strain analyses are shown per the American Heart Association guidelines and noted in the curves in figure B and C respectively. In results, the EGSR less than median group consists of more women, often had coronary artery disease, no myocardial infarction, and was less likely to suffer atrial fibrillation in comparison to the other group. Half of these patients used diuretics and more than 70% used ACEI, beta blocker, and aspirin medication. During a median follow-up of 9.2 years, 72 patients experienced primary outcomes, including 18 all-cause deaths and 54 heart failure hospitalization. Comparing with EGSR greater than median group, the worst EGSR group showed more common diastolic dysfunction by echocardiography, lower LVEF, larger left ventricle, larger left atrial size, and a greater LV mass index by CMR, and more significantly decreased GLS, GCS, GRS, and the corresponding strain rate. Regarding the correlation with clinical and imaging variables, EGFR showed modest but significant correlation with heart rate, and worse EGFR is associated with both larger LV size and impaired LVEF. By Kaplan-Meier analysis, participants with an EGFR less than 1.57 per second were more likely to reach primary outcomes. Patients with GRS greater than median were also related to higher incidence of primary outcomes. The univariable cost regression indicated that knowing myocardial infarction, LGE present, GLS, EGFR, and SGLSR was significantly associated with primary outcomes. In multivariable cost regression showed that EGFR less than median was the only stream parameter that independently associated with primary outcomes after adjustment for confounding variables. The C statistic of multivariable model is 0.64. Sensitivity analysis was also performed excluding patients with heart rate greater than 19 BPM, and EGFR remained a significant predictor in all outcome analysis. In discussion, firstly, global early diastolic longitudinal strain rate less than 0.57 per second from feature checking is a strong risk factor independently associated with all-cause death and heart failure hospitalization of half-half. In addition to the indirect tissue Doppler indices, EGFR was introduced in this study to directly reflect diastolic dysfunction. In our study, although patients showed more severe abnormalities of GRS, SGLSR, and EGLSR in univariate analysis, only EGFR remained as the only stream parameter independently related to primary outcomes. Compared with other stream parameters, EGFR might be the earlier markers in predicting the prognosis of half-path patients. Secondly, half-path patients with lower EGFR had more abnormal geometry, more impaired cardiac function assessed by echocardiographic and CMR indices. In conclusion, diastolic dysfunction can be reflected by feasible and sensitive EGFR using CMR in half-path. While EGFR is independently associated with all-cause death and heart failure hospitalization, future prospective large-scale and multi-center investigations are needed to verify the prognostic value of myocardial strain in half-path patients. However, some limitations are still existed. First, this is a single-center retrospective study. Second, the common stream marker GLS showed no significant correlation with the prognosis of half-path in multivariable analysis. Third, a variable selection was applied in Cox regression analysis to avoid possible overfitting, and not all variables were included. Fourth, as only 18 patients experienced all-cause death, observed the significant between stream parameters and death. These are the article references. Well, fortunately, this article was now accepted by the radiology, and this is the end of my presentation. Thank you.
Good day, Professor, colleagues from Asian Society of Cardiovascular Imaging. My name is Habibie Arifianto, cardiologist from Indonesia. Thanks for Asci 2021 committee for the opportunity to share my research on this prestigious and honorable meeting with entitled Rush Perfusion Myocardial Computed Tomography, novel imaging marker for left ventricular ejection fraction recovery in systolic heart failure patients. This is my disclosure. There was nothing to disclose. As we know that the heart failure is the end terminal of every cardiovascular and metabolic diseases. Unlike other developed countries like US and Europe, we are in Asia still facing the same problems. There was still high prevalence in diabetes, ischemic heart disease that would lead into high prevalence in heart failure populations. And as we know, as we see here, Taiwan and Indonesia is still facing the biggest prevalence in heart failure on their populations prevalence. And alongside with other Asian countries, which is still high in also in prevalence in heart failure. And how about the health costs? Most of our Asian countries still facing the same problem as the developing countries. With middle and low income, they spend only 14% of the overall heart failure costs globally. And this is become a big question. What can we help as a cardiovascular imaging community to search more budget-friendly diagnostic tools to help stratify the prognostic of heart failure patients? We know that the CT, computed tomography, for heart failure population can act as anatomical study to assess coronary cause for heart failure patients. But luckily, there was something left we can do with this data set. Despite only coronary informations, we can also find the ischemic burdens. In 2007, George et al. Has demonstrated the rest myocardial perfusion that would help us identify the affected segments of the myocardium which has low perfusion by determining the Hounsfield unit of hypoenhanced myocardial segment. The hypoenhanced segment can reflect the poorly contrast perfusion on the ischemic or non-viable area with significant stenosis lesion on the coronary vasculatures. And this is for our research that there was a 47 consecutive patient with heart failure with reduced ejection fraction in 2018 with reduced that enroll in 11 smart heart failure clinics programs in our hospital. And the 47 patient which is eligible for the contra-CT study was sent to perform a CT angiography for searching for coronary etiology and evaluate rest perfusion segments. And the patient will routinely control at our heart failure clinic to make sure that they've got heart failure guidelines directed medical therapy from the ESG 2016 guideline on heart failure and also from the American College of Cardiology guidelines on heart failure patient. And then after 6 months of the GTMTs, the patient was re-evaluate the echocardiography and we can analyze the result of the improvement of the left ventricle ejection fraction. As we know here, we can see from the baseline characteristic on our patient that we divide the patient, the 47 patients into two large groups. The first group is patient with 2 or less resting hypoperfusion segment, and the second group is the patient with more than 2 rest hypoperfusion segments. We can see here from the baseline characteristic, there was no difference between two groups on age, sex, and also in risk factors such as diabetes mellitus and also hypertension. And there was also no difference in between initial left ventricular or left ventricular ejection fraction and also on the right ventricular function that we can see here on the TAPSE, the tricuspid annular systolic excursion. And after 6 months of guideline-directed medical therapy, we can see here on the red box, we can see there was a significantly difference on left ventricular ejection fraction evaluation and also for the delta LVEF, which can see more clear on the slide after this. And we can see here that like we see on the data, that in the first group, the groups below 2 segments of the rest hypoperfusion, there is a significant difference between a 6-month LVEF evaluation with the P is 0.047 and also for the delta LVEF, which is it's below 0.001, which is statistically significant. And also in the groups with the more 2 segment of rest hypoperfusion also have the same improvement on LVEF but unfortunately, there was no statistically significant. And when we see the analyze from the area under the ROC curves, we can find that in the groups of patients with less than 2 hypoperfusion segment on the rest perfusion, the CT has the area under the curves of 0.789, which is the same with sensitivity of 72.2% and a specificity of 81.1% for predicting improvement on left ventricular ejection fraction on 6 months after optimal medical therapy on heart failure with reduced ejection fraction patient. And from the study, we can make out of the conclusion that the multi-slice computed tomography is a one-stop solution for a cardiologist in heart failure patient to detect coronary problems in chronic heart failure and also to do risk stratification to have prognostic value in predicting improvement of left ventricular ejection fraction in patients with less than 2 rest hypoperfusion segment with 72.2% of sensitivity and 81.1% specificity. And the most important is the coronary CT surface is widely available in almost all hospitals can perform the coronary CT easily and it's less invasive, more convenient, and the most important in developing countries like the most Asian region has is the cost effective in as a predictor of the LVEF improvement in heart failure with reduced ejection fraction. Okay, that's all from me. Thank you for your attention. Thank you very much and have a nice day. Thank you.
Before we start the next slide, I have a quick announcement. Officially, we do not have a discussion session, discussion Q&A in this session. So, but there are a few questions from the audience. Therefore, if the speaker can answer to the question, please use the chat or Q&A box. Thank you.
Hello everyone, I'm honored to share my research with you at this great meeting. I'm Bai Yanzhuang from Peking Uni Medical College, Fuai Hospital. My topic today is identify ischemic infarct, remote and normal myocardium by stress and rest mapping without the application of gadolinium contrast agents. As we know, coronary artery disease, CAD, is one of the major health problems that cause death worldwide. To early detect and accurately diagnose CAD are very necessary. Revascularization of stenosis artery through intervention or thrombolysis is helpful to save the myocardium before irreversible myocardial necrosis occurs. Therefore, it's important to obtain information about the function of the myocardium covered by stenotic coronary. Although invasive coronary angiogram (ICA) is the gold standard for diagnosis of CAD, up to 60% have no obvious coronary stenosis. So to avoid unnecessary invasive procedures, many non-invasive methods have been proposed as a gatekeeper before ICA, including PET, SPECT, and CT. However, they all have different disadvantages, the most annoying ones being anxiety, radiation, and the use of contrast agents. CMR perfusion and LGE were also used in diagnosing the ischemic cardiomyopathy. However, the examination time is long and it also needs contrast agent. Recently, remote non-invasive CMR T1 mapping can detect abnormal myocardium by quantifying myocardial blood volume without the use of gadolinium contrast agent and without exposure to iodine radiation. Our team's previous studies have established an infarct myocardial model and explored the accuracy of T1 mapping in the detection of infect myocardium using pathology as the gold standard. We found that myocardial infection in T1 mapping matched with that in the LGET images and the TTC images. This time, our purpose are to establish a miniature SWAT model of chronic progressive myocardial ischemic and evaluate the potential of T1 mapping at rest and ATP stress as a novel method to discriminate between normal remote ischemic and infect myocardium without gadolinium contrast using pathology as gold standard, and finally improve the understanding of the pathophysiology of chronic ischemic disease and to provide a new idea of clinical individualized treatment. We established a SWAN chronic myocardial ischemic model by placing an amyloid constrictor at the proximal end of LAD after first diagonal branch. The inside of the amyloid constrictor is absorbent casing which can chronically swell by absorbing water and gradually narrow the coronary lumen. This picture is the process of our experiment. The experimental group is the chronic ischemic group, and the control group is the sham operation group. The MRI examinations are performed 1 week, 2 weeks, and 4 weeks after modeling, and the MRI sequence including cine images, rest and stress perfusion, rest and stress T1 mapping, and LGE. After completing all MRI examinations, the animals were sacrificed for pathological study, including TTC, HE, Mason, and series ride. The parameters we calculated were including myocardial perfusion result index (MPRI), myocardial perfusion result (MPR) from perfusion images, and some parameters from T1 mapping, including rest and stress T1 ECV and the reactivity of T1 and ECV, including delta T1 percentage, delta ECV, and delta ECV percentage. Now let's look at the result. In the bar diagram, the blue and orange columns in the upper row represent rest and stress T1 value, rest ECV and stress ECV respectively. We can find that the rest T1 and ECV in infected myocardium were significantly higher compared to the value in ischemic myocardium during both rest and stress. The corresponding values are also shown in the table below. The blue and orange columns in the under row represent the reactivity of T1 and ECV. We can find that the delta T1 and delta T1 percentage, delta ECV, and delta ECV percentage for ischemic myocardium were significantly lower than that in the remote and normal myocardium. Then let me show you some typical pictures of different kinds of myocardium. Firstly, the normal myocardium selected for control group. The wall motion, rest, and stress perfusion are normal, and the T1 value, ECV value, and TT scanning are in a normal range. Next, let's look at the infarct myocardium. The wall motion of anterior septum is impaired, and the rest and stress perfusion is defect. But the LGE is enhanced, and the TTC study also showed necrosis in the corresponding area, and significantly evaluated T1 and ECV were also observed in the corresponding areas. In this figure, the ischemic myocardium appeared in the anterior wall, which shows a clearly reversible perfusion defect on the stress and rest perfusion and have an impaired wall motion, but without pathologically confirmed infection or LGE. The green circle in the inferior will represent the remote myocardium, which is without perfusion defects, regional wall motion abnormalities, or LGE, and the TTC staining of ischemic and remote myocardium are normal. By studying the relationship between T1 mapping parameters and perfusion parameters, we found that rest and stress T1 are negatively correlated with stress MBF and MPR, and the rest and stress ECV are also negatively correlated with the stress MBF and MPR. Moreover, the reactivity of ECV and T1 in detection of the ischemic myocardium using imaging and histological staining as the reference standard were also performed based on ROC analysis. For delta T1 and delta T1 percentage, the area under the curve were 0.99 and 0.95 respectively. For delta ECV and delta ECV percentage, the AUC were 0.90 and 0.89 respectively. So in conclusion, the rest and stress T1 mapping has the potential to detect ischemic and infarct myocardium without the need of gadolinium contrast. On the one hand, delta T1 and delta T1 percentage can discriminate between normal and impaired myocardium, including ischemic and infarct myocardium. And on the other hand, the rest T1 value of the ischemic myocardium are less than infarct myocardium. Now let's look at the discussion. In our study, we relied on widely accepted gadolinium-based CMR techniques and pathology to define the fault kinds of myocardium, and found that pre-contrast T1 value was significantly higher in infarct myocardium at both rest and stress compared to ischemic myocardium, because the degree of fibrosis of the infarct myocardium is higher, and could be potentially used to differentiate between ischemic and infarct myocardium. This study also proved that pre-contrast T1 reactivity can discriminate between normal and impaired regional myocardium. The principle is intravenous ATP infusion leads to increased myocardial blood flow in the normal myocardium, but not the ischemic or infarct myocardium, because the arterial bed at the distal end of the stenosis lumen has been expanded to the maximum. There are still some limitations of this study. Firstly, we didn't perform segment analysis. Secondly, stress perfusion was performed prior to rest perfusion, which may decrease the test performance of rest perfusion image. And finally, the assay was performed, but no quantitative value was calculated. So this is the end of my presentation. Thank you for your attention.
Hello, my name is Junsu Kang, and it is an honor to be here and to join this conference with my study. My topic is the feasibility of deep learning-based noise and artifact reduction in coronary formation of contrast in CT. The three-dimensional reconstruction technique have been increasingly applied on chest CT to improve the diagnostic performance by enhancing interpretation. Currently, the MPR viewing in conjunction with axial imaging is a standard component of CT examination, such as sagittal imaging and coronary formation. However, the image quality of MPR, particularly those acquired on low-grade CT scanner, is often not good enough for clinical application. As showing on this picture, the image quality of thoracic structures on coronary formation CT differed significantly according to the number of detector. Low CT scanner and 64 low MDCT had highest image quality. And this is the example for coronary formation of CT images of 16 versus 320 detector CT images, and the image quality is quite different. So several image artifacts such as stair-step or rippling on MPR images are exist on this scanner images, and the capacity to apply the high-end reconstruction technique program is not enough due to limitation of computational power and the compatibility problem. And the advanced reconstruction technique have limitedly conducted on transaction images. However, still demands by several hospitals for better image quality for small number of detector CT scanner. On the past few years, there were many investigations for the using CT image deep learning to reduce CT artifact. However, in clinical practice, it is challenging to obtain the ground truth because we don't know exact artifact-free images. To improve this issue, various reconstruction methods have been proposed, and the GAN is the latter mostly used method to address image correlation using unpaired artifact-affected and artifact-free images. So we suppose that GAN-based deep learning could be applied to reduce image artifact by using reference images of high-end CT scanner. So we did to speedily review the chest CT of patient who underwent chest CT scan more than twice with different CT scanner of 16 and 320 detector CT and exclude some poor image quality, and the image have a significant difference between the two image scan. So finally, 160 image sets for 80 patients were collected, and among them, 55 patients were used for training and 25 patients were used for internal validation. And this is the representative images of training set. And for external validation, 30 image sets which are acquired from other institutions by different 16 detector CT scanner and applied denoising processing and compared image quality by same method. And table 1 is a vendor and CT parameters for information for the data set, and the slice thickness of external validation set is just 3 millimeter, and internal validation set is 1 millimeter. This is quite different. And to train these unmasked images, we adopted the GAN framework proposed by Park et al. And the generator learns the generated corrected CT images from original CT images, and the discriminator learns to distinguish between the real image and image generator. And this is the network architect of the proposed network. These pictures are test result, and figure A is original image CT origin, and figure B is collected images, which means deep learning based collected images, and C is subtracted A from the B. For the internal validation, the quantitative analysis for stair-step artifact was measured the consecutive CT numbers of thoracic aorta on coronary formatted images, used MATLAB, and calculated coefficients of variance using following equations. For the objective image quality assessment, the image density and noise for aorta, pulmonary artery, lung, and liver were measured, and calculate the CNR and the SNR for each structures. And then for the subjective image assessment, all CT were independently evaluated by 3 radiologists, were blinded to patient data and grading image contrast, conspicuity, and image artifact using the 5-point scale. Here are the results. The internal observer arguments were relatively good, and the stair-step artifact of internal validation set shows the CT correct was significantly lower than CT origin, and external validation set shows a concordant result. And mean CV in corresponding 320 CT was a lowest value among the 3 kinds of image set. Image noise and house feed unit, CT collect showed the significantly lower image noise, and CT number of aorta, pulmonary artery were higher in CT correct than CT origin. However, lung and liver did not significant differ between 2 reconstruction methods, and SNR and the CNR was higher on the CT correct images than seen in CT origin image. This is quantitative analysis results. For example, the aorta showed a higher CT value and lower image noise, and improved the SNR and the CNR on the CT correct image than CT origin. On the external validation, hospital A and B, most of the results were concordant with internal validation set except for pulmonary artery. Pulmonary artery for hospital B showed the image noise and the CNR is not significant different between CT origin and correct. And the subjective image quality, CT correct shows a higher image contrast, lower image artifact, and best conspicuity in all three structures in internal validation set. And external validation set, most results were consistent with internal validation set except for the pulmonary artery. In hospital B, is no significant improvement, and it is very concordant result with objective image analysis. This is the representative images of the internal validation set, and the CT quality image showed relatively good SNL and the CNR and less image noise, and the stair-step artifact are relatively improved. And noise of the river is significantly improved on the CT correct. This is the representative images for external validation, and hospital A showed the significant improvement of image SNR and decreased image noise. And hospital B showed the pulmonary artery is not improved significantly after correction on these two images. So we speculated that the contrast boosting effect on the pulmonary artery may result more exaggerated homogeneous enhancement of pulmonary artery. Here are the limitations, and CT value of aorta pulmonary artery was significantly increased on dim running images, which may be undesirable effect on this reconstruction, while the lung and liver did not significantly differ between the two methods. Second, to evaluate the stair-step artifact, we calculated the CV of aorta for quantitative comparison. However, with CV, it is also influenced by the image noise, thus it is hard to decide actual effect of stair-step artifact. And third, the image noise and CNR or pulmonary artery in hospital B were not significantly improved on CT correct images. The image set of hospital B acquired using different vendor CT scanner and acquisition protocol that may affect the different result on this image quality. In conclusion, the dim learning based artifact correction method significantly improved the image quality by lowering the stair-step artifact and image noise in coronary formation CT. However, the dim learning also influenced other image features such as contrast enhancement, which were unexpected effect. So our study suggests that the use of dim learning has the potential to improve image quality of MPR images, even for image acquired using CT scanner, having a small number of detector low or relatively small rotation time. Thank you very much for your attention.
Hello, my name is Asci. I'm a radiologist working at Tudor City Hospital, Vietnam. It is my honor to present our study. Data analysis of many distribution multi-one mass and extracellular volume in patients with heart failure compared with healthy controls. Non-ischemic heart failure is widely prevalent disease characterized by myocardial dysfunction resulting from radiolicosis. Recent studies have shown that sequence and ECV map technique provides a new insight into the quantification of fibrosis infiltration or scars. Data analysis is the technique used for the quantification of image data. Quantification of intrinsic heterogeneity of different tissues and lesions is necessary, and they are imperceptible to the human eye. In our study, we assessed the T1 maps in ECV values of the LV using cataract MRI. We hypothesized that the extractions of the tester cataract MRI using T1 maps in ECV could reveal the tester that differs between pathological and normal myocardium. Radiomics of native T1 map could characterize the cardiomyopathy of non-ischemic heart failure. This retrospective study includes 23 patients with non-ischemic heart failure and 25 matched healthy controls. The diagnosis of non-ischemic heart failure was based on clinical examination, echocardiogram, coronary artery angiogram, CMR, and myocardial perfusion spec. Healthy controls without systemic illness or history of cardiovascular problem. It could observe that the CMR has worse image quality. The CMR scans were performed on the three-satellite scanner, Skyra with the system canal cardiac coil. The protocols of native T1 maps were obtained using modified Morley, and ECV were calculated 12 minutes after gadolinium-based contrast agent 1.5 dose on 14 view. Tester analysis of T1 maps were performed with live. We also measure the bone thickness in our diameter of LV using Asci software. The ECV will calculate with regions of interface the raw pre and post contact agent with this equation. Tester analysis applications is process of 6 steps. MRI acquisition, region of interest definition, region of interest of pre-processing, feature extraction, feature selections, and classification. Here's a RRI definition. And here, RRI pre-processing. We draw the myocardium in the four-chamber view. We set the minimum and maximum for the threshold from 800 to 1700. The number of raised level was 64. We did this for set in the heart failure in the normal group. And here is the feature extraction. We have the first order feature, such as conventional histograms and such. The second order feature lies the right level co-occurrence matrix, the neighborhood's right level difference matrix, the right level run length matrix, the right level run length matrix. T1 maps were extracted with a total of 47 tester features. The tester features derived from the T1 mapping of health in patient and healthy control were compared. These tests were performed. Correlation between ECV and bone thickness were assessed using Pearson tests. And here's the machine learning. Here's our results. Looking at this slide, we can see the thickness of the interventricular septal bones and the free bones had no difference between heart control and heart failure. However, patient has a larger outer diameter of LV than normal. Native T1 values were significantly higher in non-ischemic heart failure patients, with the mean value were 1310 milliseconds compared to normal control 1208 milliseconds. However, ECVs saw no difference, 29 and 27. The results of the t-test in this slide show that most of the histograms feature has no significant variation between non-ischemic heart failure and healthy controls. Contrary to the above results, the several second-order testers like the right lower zone length matrix, the right lower zone length matrix, so significant differences. To compare between the radiomics and native T1 analysis, present value from the fetal extraction process were calculated using algorithm. We evaluated some classifier, namely nearest neighbor, supervisor classifier, logistic regression, decision tree, random forest, and naive model selection were model 1 only TA of T1 maps, model 2 TA of T1 maps every site and every synchronous. This table shows the summarize of type and the number of the parameters selected by machine learning. If we use the native T1 only, the predictions were 89.5% using 37 parameters. If we add the average size and thickness, the predictions were 93.75% using 47 parameters. Here are the base of the tester parameters. They were obtained by the feature selection algorithm. In this study, we used level 1 output validation. When analyzed in the host failure works, we found that everything was inverse to ECV. In conclusion, TAs of T1 maps and ECV saw a difference in the mean value of native T1 and tested features. Machine learning uses the native T1 maps can use a predict rate of 89.5%. Machine learning uses native T1 maps every site and thickness can use a prediction rate of 93.75%. Radiomics of native T1 maps appear promising for characterizing the cardiomyopathy of non-ischemic heart failure. It is potential for predictions of prognosis in the future study. Thank you for your listening.
Thank you. I would like to thank to all 5 speakers for their excellent presentation and outstanding research work. As I announced, the certificate of Best Young Presenter Award finalist will be mailed to all 5 finalists in a hard copy, and the final winner will be announced in closing ceremony of Asci 2021. With that, I would like to close this session by thanking all the speakers and all of those who have taken part in this session. Thank you for joining this session, and I hope you have a good and tasty lunch. And thank you. Bye-bye.
To the dreamers who imagine the impossible, who inspire the world with their ideas, and strive to provide clear answers. for early and accurate diagnosis, for better outcomes, for better health, for every patient. Bayer wants to join you and make this dream come true.
My journey continues, and I know I'm not alone.
Nào bác sĩ Ánh à.
Because
Hello?
together we can make a difference every
Anh đi đâu
day.
rồi?
Em chào thầy.